Yeah, that sounds.
Uh, yeah, let me clear the recording thing. So Academic Cafe Day this morning, as you may or may not know, we sometimes will invite various members of our different pathways or educational experiences to help us lead and think about things related to Academic Cafe Day. And the Women's Health Pathway members have long done some great teaching around women's health issues, and for many of us that may not have as much familiarity and comfort, we always learn a lot from these sessions. And so I'll ask each speaker when they do their own to go ahead and say a couple words about themselves for any other residents that may not have worked with them directly. So take it away, Becca.
Yeah, thanks. Thank you for the doing our intro, Dr. Cho. I'm Becca. I'm an R3. I'm in the primary care track and the women's health pathway. I'm really excited to chat with you all this morning. We've got a nice lineup of R2s and R3s. I'm going to do my best to look at the chat, but appreciate anyone interrupting me if I am missing things, and then should be hopefully time at the end for questions.
Can I
Um,
also add, just because I know this is true when I give a talk, if you guys want to support your co-residents, please turn on your cameras. I know that it's very welcome to be able to see some happy smiling faces and comforting indeed. So please feel free to do so if you're comfortable doing so.
Thank you. So I'm going to do our first talk. We're going to give a little bit of shorter talks to make sure we get through all four. So I'm going to start the morning by talking about breast concerns. And I wanted to just start by giving a big shout out to the incredible women's healthcare faculty, past and present. There are more than the folks listed here on this slide, but these individuals have given prior talks on breast concerns, and were nice to share some slides and give me some feedback. So the format of today's talk, I first just have no disclosures. I'm, of course, not a breast expert, and I don't have any financial disclosures. I'm hoping after this morning that you'll have a better sense of just the basic anatomy of the breast and the chest wall. We'll do a refresher on the clinical breast exam about what is it and when you should do it. And then hoping to help you all develop a framework for approaching some common breast concerns that you'll see in clinic, including mass, pain, and density using some mix-up questions. So with a little bit of background, the reason why I think this talk is important, as you will go along in your training, you will have folks across the gender spectrum, and really all of our patients do have breast tissue, regardless of their gender identity. Mastalgia or breast pain is an incredibly common complaint in the primary care setting. About 70%, it's estimated, of women at some point in their life will have pain in their breasts. And breast cancer is the most common cancer diagnosed and the second most common cause of cancer-related death in women in the US. It's estimated currently about 1 in 8 women will experience breast cancer at some point in their lives. There are also very notable health equity concerns related to breast cancer. For example, white women, although 6% more likely to be diagnosed with breast cancer compared to Black women still have a 40% higher mortality rate compared to white women. And there really are racial disparities that occur at every step of the breast cancer continuum, thinking from screening to diagnosis, treatment, and then survivorship. One area that's often cited to explain this higher mortality rate is that Black women tend to present at a later stage of their presentation when they are diagnosed, which speaks to inequities in screening in particular. Um, these sort of disparities exist at a number of different levels, thinking about systems levels factors that might impair screening, like insurance, engagement in primary care, or accessibility of mammograms. And then also thinking about patient level factors like mistrust, understandably, of the healthcare system, or cost, or sort of competing individual needs or requirements. And I'm not sure if you all have seen this, but the USPSTF actually just came out with a new guideline that lowers the recommended age for when to start at very least talking, if not screening, women from 50 to 40. And some of the research that's cited for this change showed that it would be more equitable for Black women to begin screening at this younger age. And then I want to just give a quick specific shout out to some amazing research that's recently come out of UW. The first author here is UW alum Anisha, with work with faculty Dr. McClintock and Dr. Young. So their study was looking at UW data from 2019, specifically white and Black women who received primary care within the UW medicine system. And similar to that USPSTF recommendation, they stratified women into two age groups, those 40 to 49 and 50 to 74. And what they found is that at each step across this continuum of completing a mammogram, so from referral to scheduling to completion, one finding, unfortunately, was just drop-offs among all patients of completing. But then really quite notably in their fully adjusted analyses for both age groups, they found that Black race was associated with a lower rate of completion of mammography. And you can see with the odds ratios that that effect is even more notable in that younger age group. So just one example of the really important work that UW alum are doing. Okay, transitioning now into our first mix app question, and I'm going to hope that some brave folks will volunteer to read this for me.
I can read it.
Thank you, Tony.
So this is a 44-year-old female who's evaluated for a breast lump she noticed 1 week ago. There is no nipple discharge. She birthed 2 children, the first at age 25 years old, and her menstrual cycles are regular. She has no family members with breast or ovarian cancer, and she has no other medical problems and takes no medications. On physical exam, her vital signs are normal. Her BMI is 28, and on exam, her breast revealed dense tissue bilaterally and no skin changes. A mass is noted in the upper inner area of the right breast, measuring 1.8 centimeters. It is firm, mobile, non-tender, and has ill-defined margins. There's no evidence of axillary, cervical, or supraclavicular lymphadenopathy, and the remainder of the exam is unremarkable.
Thank you, Tony. So which of the following is the most appropriate diagnostic test to perform next? And I'm realizing as we're hitting this slide that Karen was going to launch polls for me. And I don't think that she's on the call. So, oh,
Launching it for you right now.
yay! Oh, Karen, I'm sorry. Thank you so much. So while Karen's doing that, I'm going to read the STEM. So their options are A, breast MRI, B, a core needle biopsy, C, diagnostic mammography, D, diagnostic ultrasound, or E, diagnostic mammography and ultrasound. Thank you, Karen.
Of course. A few more seconds to end the poll.
Okay, good. I'm excited to see a little bit of a spread here. So it seems like the most frequent answer was both a diagnostic mammo and an ultrasound, but we had almost equal votes for each individual option. So the correct answer for this question is E, to do both a diagnostic mammogram and an ultrasound, and hopefully you'll learn more about why. So when you're thinking about seeing someone in clinic with the chief complaint of a breast lump, I think one framework or sort of easy way that you can ask yourself is the big question that you're trying to answer is, are you worried that this is a malignant entity or is it benign? And the way that you're going to help yourself answer that question is by taking a really good history and doing a physical exam. So just to kind of reminder, I think for malignancy, we all have a decent framework of what we are thinking about mostly breast cancer. But to talk briefly about benign entities of the breast, some other things that you could be thinking about are a fibroadenoma, a cyst, fibrocystic changes, galactocele, fat necrosis, or an abscess. Fibroadenomas, I feel like folks are typically aware of. These are benign, more kind of solid but mobile masses that are really common in young women. Cysts can range anywhere from simple to more complex. They are fluid filled, so they're usually a little more blottable on exam, but typically pretty solitary. And then fibrocystic changes, again, very common in premenopausal women. This is usually more of sort of a diffuse and generalized tenderness. There's rarely as well of a defined or discrete mass, and it tends to occur more in sort of the upper outer quadrants of the breast. Galactocele, as the name suggests, is milk retention in folks who are breastfeeding. And then fat necrosis usually occurs after some kind of a blunt force trauma to the chest. You might see ecchymoses or evidence of that on your exam. And then breast abscess, I'm going to save for a little bit later. So as I mentioned, to help you decide and kind of weight your differential as you're thinking about what this could be, the first step is taking a really good history. So the first thing you're going to think about is sort of asking the patient for changes in general about the size or the contour of the breast. Have they noticed skin changes, nipple inversion, or any discharge? If the patient is having discharge, it can be helpful to know whether it's bilateral or unilateral, whether it seems to be involving just one duct or multiple breast ducts. If the discharge has a color, is it bloody, kind of what time of day, are there triggers, and then is there pain in the breast as well? The mass itself can be helpful to know if it's changed over time. Does it change with menses and where it's located in the breast? Again, asking for a history of trauma, thinking about fat necrosis, and then briefly just going to touch on some breast cancer risk factors, but Tony's going to do a full talk on this later. So it is helpful to at least know just sort of basic risk factors in every patient. So thinking about their age, if they have a family history of breast cancer, sort of an OB-GYN history about when they went through menses, if they've had any births, the age of the first birth, if they've gone through menopause, have they used birth control pills or HRT, alcohol use, and then if they've had any prior imaging or pathology. After you've taken this great history, you're going to transition to your clinical breast exam. So I want to pause briefly. I think this is a topic that comes up a lot with patients and even is sort of an active area of discussion as well. So this feels different than when we were in med school, I think, but the sort of updated recommendations now is the American Cancer Society actually doesn't recommend doing a clinical breast exam any longer, or even breast self-exams in patients as a routine screening mechanism for breast cancer. They've found that there's just a lack of evidence that there's truly benefit from a screening clinical breast exam alone. And there's a lack of data if this really improves patient outcomes. In fact, maybe it even just increases false positive rates. A screening CBE, though, is different than what we're talking about. We are talking about doing a diagnostic clinical breast exam, which still is a really important part of the evaluation of a woman with a breast complaint. And then I also just want to give the caveat that we are thinking about practicing here in Seattle in a really resource-rich setting. But if you were to go to another area, what was perhaps a lower resource setting, clinical breast exam is still a great option. And the WHO does still recommend CBE as an appropriate screening mechanism in more lower resource settings. This is sort of just getting back to the basics. I'm on the women's elective right now and get to spend the afternoons with Dr. Tan in breast clinic. And she does her breast exam in a very formulaic but different way than I'd seen. And I really like it. So I wanted to just share with you all briefly. So the way Dr. Tan does her breast exam is she starts with the patient actually seated on the exam table, has them lower the gown, and they start with their arms at their sides. Then she has them lift their arms overhead, back down, and then hands in front, and she has them kind of push in to activate the pectoral muscles. And what you're doing during this phase is looking for symmetry of the breast, you're looking for changes in the breast tissue, and then nipple eversion or inversion. Then with the patient still seated, she does her lymph node exam. And so you're really thinking about getting all of the cervical lymph nodes, supraclavicular, and axillary while the patient is seated. You can then have the patient lay on their back and you alternate exposing one breast at a time with the patient's arm above head. You'll see a lot of folks do different techniques. The Women's Health Clinic is a big proponent of the vertical strip method. They actually suggest that this is the superior method for your breast exam. So you will start really in the mid-axillary line and work your way using this technique all across the breast tissue up to the clavicles to the sternum. And what you're feeling for on palpation is just general texture and symmetry. You're looking for any focal or dominant lesions or nodules, taking note of their location, their size, and kind of the quality of them. Are they firm or soft, mobile, immobile? You're checking in with the patient to see if there's any associated symptoms like pain and looking for skin changes or nipple discharge. And then really importantly, when you're documenting findings, the sort of typical nomenclature is using the clock face to orient where the mass is located on the breast, and then also documenting distance from the areola. Okay, so we've taken our history, we've done our clinical breast exam. Unfortunately, because the physical exam alone is usually insufficient to distinguish between a benign mass and a malignancy, diagnostic evaluation of a breast lump does typically include imaging. And then based on imaging may include biopsy as well. So coming back to our mix-up stem, the sort of only piece of information you needed from that stem was that it was a concerning enough lump and the patient's age. So age is sort of the number one factor that you consider when deciding what the appropriate imaging modality is. In folks that are less than 30, we just do a diagnostic ultrasound alone. This is because it has a higher sensitivity, especially in patients with higher breast density compared to mammography. In someone who is 30 to 39, there is a little bit of, it's a kind of a gray zone. You will see some people argue to start with an ultrasound, again, because of that higher sensitivity. And then if that is negative or doesn't see anything, to then go on to a mammogram. There are some people who flip that order and some people who just order both. Dr. Tan shared that her practice is just to order both in this age group, and then typically radiology can help in protocoling or deciding the order of the studies need to occur. Now, I want to briefly segue to mention the difference between screening and diagnostic mammography. So screening mammography is what we think about for someone who is asymptomatic. It's covered by insurance, it's part of preventative care, and it's pretty basic in terms of the imaging that it does. It takes images from two basic angles in the sort of craniocaudal up and down plane, and then the mediolateral or side to side plane. That is not what we are talking about here. We are talking about diagnostic mammography to investigate a specific concern or a specific complaint, which is why it's so important that you document in your note exactly where you found that lesion. It's supervised actually by a radiologist while it's being performed. So that's why we typically send folks to the Fred Hutch Clinic for diagnostic mammography. And because there's a radiologist there, they're able to, in the moment, get additional images and views that they need to target that lesion. So lastly, going back to our last age group, this 40+ age group, which I believe was the one that our patient fell into. So in this group, we are thinking about getting both a diagnostic mammogram and an ultrasound. And the reason for this is that the mammogram can help look for evidence of calcifications. You can see here in this image that are concerning for malignancy, while the ultrasound can be really helpful for evaluating for cystic or more solid-like features. So in this picture, A, B, both show more kind of complex cysts. There's supposed to be a nodule there in A that you can see. C is a cyst with this little fine septate. And then D is also considered complex because it has this swirling on the inside there that you can see. And then so based on our workup here with imaging, next steps might include a biopsy if it's a concerning finding. Sometimes they will just recommend closer imaging follow-up, and some people will be cleared to sort of just graduate and go back to routine screening. The two little brief comments I want to make here is that if you feel a very clinically concerning lesion on exam, and for whatever reason, imaging doesn't find anything, that could, in some circumstances, still warrant a biopsy. So it's kind of scarily about 10 to 15% of clinically suspicious masses will be mammographically occult is the term, so they won't be seen on imaging. So just something to keep in mind. I also just want to point out a new learning for me is that mammograms are actually thought to be safe in pregnant patients. So if someone is pregnant, you can continue to refer them for diagnostic mammography or ultrasound. And then I just want to point out that MRI is not listed anywhere here. MRIs don't have a role in the diagnostic evaluation of breast masses, but they do in some patients for screening, as Tony will tell you about later. Okay, gonna pause there. Any questions about breast lumps before we move on to pain? Okay. Is any other brave soul out there willing to read my second mix-up question?
I can read it.
Thank you, Leah.
Okay, so a 33-year-old female with a 10-month history of bilateral diffuse breast pain. The pain is severe in intensity, occurring about a week before her menstrual cycle and resolving afterward. She has generally lumpy breasts without a dominant mass and no nipple discharge. Her menstrual cycles are regular. She drinks a cup of coffee in the morning and another at noon. Medical history is otherwise unremarkable. She has no family history of breast cancer. On physical examination, vital signs are normal. BMI is 29. Examination of the breast shows dense nodularity in the upper outer quadrant of both breasts and no skin changes. Tenderness is elicited on examination of the upper outer quadrants of the breasts. There is no evidence of cervical, supraclavicular, or axillary lymphadenopathy.
Thank you, Leah. So For this patient, which is the most appropriate next step in management? And Karen, if you can launch our poll, that would be awesome. So the options are A, to advise avoiding caffeine, B, to use a well-fitting bra, C, getting an ultrasound, D, a diagnostic mammogram, or E, prescribing danazol. I may have just given that one away since I can't pronounce it. That might not be the answer.
Just a few more seconds before I close the poll.
Okay, also a nice spread on this one. So most people liked a well-fitting bra, but some votes for caffeine, and then some other votes for doing, someone voted for Danazol, probably just to troll me, and then some other folks want to do some imaging of some sort. Okay, so the right answer for this one is to advise a well-fitting bra. So a framework I'm going to suggest for thinking about breast pain, kind of harkening back to days of med school, I'm going to suggest that the first thing you should ask yourself are, what are your sort of can't miss diagnoses? One I'm going to argue is mastitis, because it's fairly different in your management. And the other, of course, is breast cancer. So mastitis, we'll talk a little bit in a moment, but thinking about if there's actually a true painful red or swollen breast, if the patient has fever, breast cancer, as we just went through, if there's a palpable, focal, kind of concerning skin changes, nipple discharge, lymphadenopathy, that's going to send you down the lump workup pathway. The other, so briefly, just want to talk about mastitis is something I think in med school I thought could only happen in folks that are breastfeeding, and that's really not the case. We actually last week in WAC clinic with the med students saw a woman with mastitis. So this is something that your patients will come in with. Non-lactational periductal mastitis is caused by inflammation of the subareolar ducts that then leads to periolar inflammation. And then patients can develop secondary infections on top of this inflammation. Infections, like anywhere else in the body, can start at just the cellulitic level. They unfortunately then can develop abscesses, and then some eventually into draining fistulas. The majority of the bugs that seem to be responsible for this are staph, anaerobic strep, enterococcus, Bacteroides, and Proteus. It is still really a clinical diagnosis. Ultrasound has a role if you're worried that there is an abscess due to fluctuance or it's not improving. And then if there is any drainage from the nipple or otherwise, you can send that for gram stain or culture. Treatment is typically an antibiotic course. UpToDate recommends Augmentin as sort of your go-to antibiotic, usually for 5 to 7 days, but you can extend to 10 to 12, or Bactrim or Doxy if there are risk factors for MRSA exposure. If someone has an abscess, it will require, in fact, IND. Dr. Simon says that most PCPs should feel comfortable doing this. If you do not feel comfortable doing this, though, you can refer to breast surgery, who can help with that. And they, of course, would manage fistulas as well. The other plug I'll make is it sounds like tobacco use is actually a big risk factor for this. So also doing some counseling on smoking cessation. Okay, so we've ruled out our can't misses. And now the other question you should just ask yourself is it really the breast? So extramammary pain, just how not all that pains on the left side is the heart, not all that pains in the chest is the breast. So a brief reminder of just basic anatomy here. The breast tissue itself is both fatty and dense, as we'll talk about later. And it sits atop the chest wall. Behind the chest wall, or within the chest wall, is the pectoralis muscle, your ribs. The breast itself is innervated by intercostal nerves, and then you can see the lymph node chains that run above and lateral to the breast. So extramammary pain typically, although this is a little bit more vague, typically is more often unilateral. It's typically more very lateral or very medial to the breast. The history might share that it's brought on by activity. Similar to costochondritis, it could be reproducible on a specific area of the chest wall on exam. And then it also can be referred, as I said, because of the intercostal innervation from other areas of the body. So things like other medical problems, biliary disease, a pulmonary infection, esophageal spasm, or cardiac pain. A woman could present thinking that it's her breast that is painful. And then given the anatomy of where the breast sits, certainly MSK can be a very large contributor to pain in that area as well. But once you've decided that we are really thinking about true breast pain, the next question that you can ask yourself and trying to figure out etiology is whether this is cyclical or diffuse or more non-cyclical or focal breast pain. And the reason this is important is that in our clinic, we use the term like a mass equivalent, that if someone presents with focal, non-cyclical breast pain, this is more concerning for possible malignancy and would warrant additional workup with imaging, similar to what we just discussed with a lump. But if someone rather has more cyclical and diffuse breast pain, there are no concerning features on your exam, and they're up to date on their breast cancer screening, you can really kind of provide some reassurance that breast cancer is incredibly unlikely in this case, and really no imaging is probably needed. Rather, you can just provide some reassurance and talk to them about different treatments. The American College of Radiology says that in one study, about 0 to 3% of breast cancer manifested with pain alone. So you can tell your patients, hopefully that helps with some reassurance. So thinking about cyclic mastalgia, which was the topic of that question stem, it typically is more bilateral and diffuse as the patient was experiencing. It tends to often be most severe in the upper outer quadrants of the breast and is often worse in the few days before menses. So just a quick reminder of this chart from when we all learned about the menstrual cycle. Typically, the pain with cyclical mastalgia begins during the late luteal phase and then will dissipate with the onset of menses. So with ovulation, there tends to be stimulation and proliferation of the normal breast tissue. Estrogen tends to stimulate the ductal elements, and then the stroma by progesterone, and then prolactin can play a role as well in ductal secretion stimulation. Some people argue too that hormonal agents like HRT and OCPs can have similar effects due to hormonal changes. Again, imaging is not really recommended in this group unless you find a focal or concerning mass on exam, and really just providing reassurance and education is the #1 step. About 85% of women who have this pain, it will just be self-limited and will resolve, and about 15% will go on to want to desire some kind of treatment. So for folks in this group, the first line therapies are physical support, like a well-fitting bra, thinking about hot or cold compresses, Tylenol or NSAIDs. There is sort of mixed data on whether or not stopping HRT or oral contraceptive pills help patients. Some providers anecdotally feel like starting OCPs can sort of provide a more stable hormonal level rather than those peaks of menses. So I would say data's a little mixed here. And then Up to Date points out that there is a lack of good evidence for caffeine abstinence or evening primrose, but a lot of providers still do talk about this with patients. And then really second or third line, if folks are still really refractory and really suffering, you can think about tamoxifen, recommended over danazol, about 10 milligrams a day, only during the luteal phase of cycle. But there's pretty significant side effects to both of these medications, so we'd want to do a lot of counseling before considering this. Okay. Our final topic of the morning is breast density. And just for time, I'm going to read this one. So this is a 50-year-old woman. She's seen following her screening digital mammography. She's asymptomatic and has no medical problems. Other than age and sex, she has no additional risk factors for breast cancer and no family history. The mammogram report notes no suspicious lesions, but indicates that the breasts are heterogeneously dense, density category C. On a previous physical exam, vital signs and breast exam were normal. So in addition to education about breast density, which of the following is the most appropriate adjuvant breast cancer screening? Karen, thank you for launching our last poll. The options are A, breast MRI, B, digital breast tomosynthesis, C, repeat digital mammography in 6 months, or D, no further testing. Great. Oh, I love it. Okay, great. So real split here. Majority of folks actually voted for breast MRI, and then the other half answered correctly, which is no further testing in this case. So I wanted to just briefly talk about breast density. I have found that patients are increasingly bringing this up during wellness visits and having questions, or even scheduling unique visits just to talk about these letters that they're receiving. So a reminder is that the breast tissue is made up of both glandular tissue and then supportive tissue. Breast density is calculated on the mammogram, so it's not at all related to exam. And it's calculated as the ratio of dense breast tissue, which is comprised of glands, ducts, and that supportive tissue, to the more fatty tissue. So moving from left to right, you can see that on the left, this breast is almost entirely fat. B shows a little bit of scattered fibroglandular tissue. C is becoming more dense, and then D represents extremely dense breast tissue. And as you can see, density is bright white on mammography. So as you may have seen on your patient's mammogram reports, a lot of folks now are receiving these letters in the mail or in MyChart after they get a mammogram. So many states have adopted a range of different dense breast legislations that at a minimum require patients to be alerted that they have dense breast tissue, that it's a risk factor for breast cancer, and then recommending that they talk to their doctor about more information. And there actually was just a new piece of legislation that was passed by the FDA called the Mammography Quality Standards Act. And that's going to require that all patients across the country are notified, and this should be rolling out this coming year. So probably will become an increasingly discussed thing in clinic. Basically, the two main things that you should think about with breast density, it's incredibly common. About 43% of women in the US have dense breast tissue, so fall in either that category C or D. And then over the life cycle, breast tissue does tend to become less dense, but this can be impacted by hormonal medications that kind of slow that transition from dense to more fatty tissue. There is some subjectivity in sort of scoring these breast densities. Another reason why we recommend folks go back to the same place for their mammogram every year if able. And the important things to talk with patients about are that breast density can impact screening in two ways. The first of which is that it can decrease the sensitivity of a mammogram to detect smaller lesions. So as I showed you in that image, density appears bright on mammogram, as does cancer typically. So in this study, they found that the sensitivity of a mammogram in a patient with almost entirely fatty breasts was 88%, and that dropped all the way to 62% among patients in the denser breast category. The second thing to think about is that density does appear to be a risk factor in and of itself for developing breast cancer, because most cancers develop in that glandular parenchyma. This table shows sort of the relative risks of developing cancer. So for folks in D, breast density, it's about 2, and then C, it's about 1.2 to 1.5. The one important thing, though, to mention is that there's been no studies that show that density itself increases breast cancer mortality, and we still just don't have enough data to support that additional testing is warranted in these folks, or that this makes any impact on their breast cancer mortality. I put the little language here that UpToDate provides that I thought was helpful about how to talk to patients about what this means. So if someone has a category C, that's equivalent to having the risk related to a second-degree relative with breast cancer, and category D is the same about risk of having a first-degree relative. And then I'm going to stop there. I'm sure Tony will talk more about different risk calculators that you can use and how density might factor into that. But just a reminder for that question that just having dense breast tissue in and of itself doesn't require any additional workup beyond that. So I will stop there. Any questions? And thank you for your participation and for turning cameras on for so many folks. It was really nice to see faces.
We have one question in the chat. Is there a different mammogram that can be done with dense breast?
Yeah, Carrie, such a good question. The short answer is no. Last week in clinic, Dr. Tan was talking about a contrast enhanced mammogram for some folks that are more higher risk. I don't actually even know if that's offered yet at UW. And as Tony will probably talk about, in some patients, we do think about MRI for screening, sort of for this reason, in part because it is a less sensitive modality in folks with denser breast tissue. But for now, for screening, if you are average risk and happen to have dense tissue, we just stick with mammogram for now.
Thank you so much, Becca. It was a great presentation. We'll take a 5-minute break, return to our second presentation by Leah Carlson.